Hello, everyone, and thanks for listening today to this pre-conference session at Virtual Fast Track Cities 2020. This is part one of the session on service delivery. My name is Dr. Anna Grimsrud, and I'm the lead technical advisor at the International AIDS Society. My presentation today is on differentiated service delivery, or DSD, scaling up what works in the face of coexisting pandemics, and these pandemics, of course, being HIV and COVID-19. I'm going to share some details of the scale-up of DSD before COVID-19, and then walk you through the 5 ways in which DSD of HIV treatment has been accelerated during COVID-19, with examples from countries and partners emphasizing 3 key takeaway messages. All references are hyperlinked, so you can download the slides and learn more after the presentation. Here is a commonly used definition of differentiated service delivery: a client-centered approach to HIV services, acknowledging both the needs and expectations of people, while also the healthcare system realities. In this presentation, I want to emphasize these 3 takeaways and some collective calls to action. That DSD is more than just antiretroviral therapy refills, requiring us to support community-based and community-led delivery of services. That DSD is more than just HIV, and beyond HIV treatment, we need testing and prevention that are evolved to be truly client-centered. And finally, that we are at a pivotal turning point of opportunity where we should conscientiously decide which innovations that emerged in response to COVID-19 should be retained as we build back better. So where were we before COVID-19 at the beginning of 2020? Well, the momentum for DSD within the HIV response had been growing, and had been doing so since the 2016 World Health Organization guidelines that recommended treat all, acknowledged that a one-size-fits-all approach was not going to be sufficient to reach global targets, and acknowledged the diversity of people living with HIV. As I mentioned, there were endorsements not just from the WHO, but broad support from those funding the HIV response. In the 2020 to 2022 allocation period, the Global Fund highlighted DSD within its 5 key investment principles as part of implementation quality and efficiency. PEPFAR, in their 2020 country operational plan guidance, included the adoption and implementation of DSD models as one of its minimum program requirements. And since 2015, National Ministries of Health have published either standalone DSD operational guidance or endorsed and incorporated DSD within national care and treatment policies. And here are some examples from Eswatini, Ghana, Cote d'Ivoire, Zimbabwe, and a hot off the press update from Uganda that was published this May. Countries are also moving from pilots to scale up, and DSD is now not just seen as an approach in high burden countries in Eastern and Southern Africa, but endorsed in other regions as well. For example, in West and Central Africa, where the HIV response has lagged behind other regions, it has been increasingly acknowledged that DSD could support HIV programs by acknowledging that adherent clients can collect ART refills without seeing a clinician, and that longer ART refills can support adherence, as well as distribution by peers, particularly for key populations, can support care. Similarly, there has been expansion of differentiated service delivery, both increasing who is eligible and increasing which services can be provided. A strong case has been made for family-centered care and the need for DSD policies to evolve to be more inclusive of younger age groups. In practice, caregivers in sub-Saharan Africa commonly attend monthly facility visits on their child's behalf without the presence of the child, and this results in a time and financial burden on the caregiver with no clinical benefit to the child. And DSD also applies beyond just HIV treatment, but also to testing, linkage, and to ART initiation. There are also concentrated efforts to meet the client's needs by integrating other services. People living with HIV have health needs beyond just HIV. Providing client-centered care means addressing other health needs, which may include treatment of other acute or chronic comorbidities, and the provision of family planning and other sexual and reproductive health services. There's been a recent push to improve TPT coverage, and differentiated service delivery models can support this by ensuring that those in DSD models who are eligible or in need of TB preventive therapy can access it through their DSD models with aligned refills and supportive screening and support done through lay healthcare workers, expert clients, or peers. Further, DSD should be leveraged to strengthen family planning. As people living with HIV are referred to differentiated HIV treatment models, this should also be used as an opportunity to ensure access to and continuity of family planning care. People living with HIV who visit health facilities every 3 to 6 months to collect their ART do not maximize the benefits of their differentiated treatment model if they need to return to the facility more frequently for the management of their other medical needs, including family planning. So clients in differentiated ART delivery models should be supported to use the contraceptive method of their choice, and where commodities are required, be able to obtain these through their differentiated ART model. Shifting now. So what has been the impact of COVID-19 on the scale up of DSD, and how do we scale up in the face of these coexisting pandemics? Critically, during COVID-19, the priority is and has been to ensure continuity of HIV and TB diagnostic and treatment services, whilst minimizing the need for patients to travel in the community and interact with healthcare workers and other patients. DSD can support this by adapting the when and the where building blocks of service delivery through reducing the frequency of visits to healthcare facilities and by enabling the delivery of services within the community. While COVID-19 may be unprecedented, it is not unprecedented for services to be adapted and for DSD to be expedited in times of emergency. We have seen this done before. There are examples of accelerated change in Guinea and Sierra Leone during the 2014-2015 Ebola outbreak, and in the Central African Republic, where 6-month antiretroviral therapy refills were distributed by lay healthcare workers at decentralized facilities during conflict in 2015. And more recently, in areas of northern Mozambique, mobile clinics known as brigades have been instrumental in ensuring continuity of services. During COVID-19, there are 5 ways which global agencies, funders, implementers, governments, ministries of health, and importantly, community has accelerated DSD for HIV treatment. The first is the extension of ART refills, and in some cases, also prescriptions. In 2016, the WHO recommended 3 to 6 monthly ART refills and clinical consultations for clinically stable clients. In the context of COVID, advocacy has pushed for all clients to have a minimum of 3-month treatment with them at all times, and to extend prescriptions for all clients to allow for greater flexibility in the face of uncertainty. This extension of ART refills during the outbreak of COVID, or the epidemic of COVID, or this push for what's called multi-month dispensing, or MMD, has been emphasized by the World Health Organization, as well as by PEPFAR, the Global Fund, UNAIDS, and UNICEF. Extending refills ensures that people have a sufficient supply on hand so that they can have uninterrupted treatment during periods of lockdown. Further, this emphasizes the difference and the importance of separating HIV drug refills from clinical consultations. Despite the guidance from WHO to do this nearly 5 years ago, there are many countries that permit that don't allow extended ART refills beyond 3 months. So in this data here from a WHO survey completed in April to June of 2020, you'll see that most countries in the navy blue allow 3-month refills, whereas very few allow 6-month refills as highlighted in green. And this proportion varies by WHO region. Further, we need to note that this is just what the policy says and may not be reflected in implementation or access. In addition to extending treatment refills, there has also been a reduction in the frequency of clinical consultations. In South Africa, where viral load is monitored on an annual basis, The National Department of Health has issued guidance to extend prescriptions for ART from 6 months to 12 months through April 2021. And this is an important step in affording options for ART refills. So beyond ART refills and prescriptions, the second and critical component in which DSD has been accelerated is that most countries have adapted service delivery during COVID-19 in terms of scaling up out of facility or community-based options for the provision of ART refills. All the countries here have issued interim guidance to expand community options during COVID-19. In some cases, these were new options, and in some cases, it was just increasing the emphasis that these could be expanded to more people. We traditionally think about DSD for HIV treatment models in 4 broad categories. We have healthcare worker managed groups, also known as clubs. We have individual fast track or facility-based models like fast track drug refills. We have client managed groups such as CAGs, and we have out of facility models, which include a number of different ways of providing treatment. And it's these last two, the client managed groups and the out of facility individual models, that have been emphasized and scaled up during COVID-19. So if we look at these in more detail, we can see that these out-of-facility models are happening in many ways. Community adherence groups, or CAGs, are being done with physical distancing, meaning that groups may still be meeting at a distance or may be used as distribution models with the psychosocial support component being done virtually. And in terms of out-of-facility individual models, or the ones here in green, which are also known as decentralized drug distribution, these have many different variations. So we see things like community drug pickup points, which could be community pharmacies or dispensing from community-based organizations or from lockers or automated dispensing machines. We also have drop-in centers, which have been very successful for key populations and other groups. We have private pharmacies that work with the public sector to dispense publicly purchased medications. We have mobile clinics. And we also have home delivery, and this home delivery could be done by peers or by couriers or by healthcare workers, and again, could be done via bicycles or motorbikes or other forms of transportations. And these models are followed globally in all of the WHO regions. And so this is takeaway point 1, that we need to ensure that multi-month dispensing is coupled with also community-based and community-led mechanisms, and these need to be funded and supported. So while private-public partnerships offer exciting potential, we should also consider how this level of resource could be directed to community-based organizations to provide services. Again, it's about being community-based and community-led. And so please stay tuned on this channel and check out the next presentation in this pre-conference session on service delivery from Solange Baptiste of ITBC, where she'll focus more on this community health delivery. The third, and back to the ways in which DSD has been accelerated during COVID-19, is that we've seen many countries take this opportunity and really recognize, as mentioned earlier, that in order to provide client-centered care, we need to address other health needs at the same time. Again, these other chronic comorbidities and the provision of family planning and sexual and reproductive health services. Ensuring management of diabetes and hypertension and TB have also become especially important and critical during COVID, where we see high risks of disease progression in these populations. And so there have been huge efforts to align drug refills and support uninterrupted care. Just a few examples below in this slide highlight that, for example, in Eswatini, community adherence group members can collect refills not just for HIV, but also for TB, NCDs, and family planning for those in their communities. And then in India, we see that TB preventive therapy refills have been extended. And the same has been done in Uganda and Zimbabwe, where the follow-up for TPT refills is recommended to take place over the phone, allowing for longer refills and less frequent consultations at the health facility. So DSD was never intended to be HIV-centric, and it actually was always described as a concept that could be applied to other health conditions. And we now see that this is a pivotal time for it to continue to evolve and meet these other health needs. And so this is the second takeaway. DSD is more than just HIV. It's client-centered care. And so this means obviously acknowledging these needs and expectations of people and the reality of the limited healthcare settings that are providing services to them. With all of the collective experience and successes of the HIV response, these have been built on this combination of activism, political leadership, and science and community-driven responses. It's time to push these client-centered programs for chronic HIV care to do more and to provide a comprehensive and integrated package of high-quality health services. The fourth way that DSD has responded to COVID-19 is by catalyzing the scale-up or implementation of DSD for HIV treatment. So not shown on this slide, but we know that in countries in West Africa, like Liberia and Sierra Leone, the COVID-19 epidemic has led to DSD being really kickstarted and implemented for the first time in these countries. The data on the slide here shows that on the left in Mozambique, there has been an intensive effort to scale up 3-month dispensing, and where there were just 491 sites reaching a few clients in March, this was scaled to 1,230 sites by the end of June and reaching over 60% of clients with 3-month ART dispensing. Similarly, in Eswatini, 6-month dispensing expanded from just 1 facility and 267 clients in December 2019 to 103 facilities and 24,000 clients by the end of May. And on the right in Tanzania, data from just one partner highlights the scale up of community ART refills that's bounded from 7,500 clients in the first 3 months of 2020 to more than 20,000 clients by April and May. And so this is just some of the ways in which we have accelerated access. Last but not least, we've seen that countries have expanded who's eligible for DSD for HIV treatment as a result of COVID. So in Ethiopia, extended refills are now available to children, to pregnant and breastfeeding women, to clients on second line, and to those who are clinically unstable. So reaching many more people. And in Zambia, those who are newly initiated are also provided with 6 months of treatment. So people don't have to jump through as many hurdles to have access. Well, now, what about DSD beyond antiretroviral therapy? And this is also extremely important. And there's also been adaptations that have happened as a result of COVID. So differentiated service delivery has always been defined as applied across the HIV continuum. Its genesis was in adapting services for clinically stable clients on treatment to support adherence, retention, and suppression. But the concept applies not just to treatment. It also applies to testing and linkage, re-engagement in HIV care, and HIV prevention. So let's talk through these components. It's critical that testing also be differentiated in response to COVID-19. We want to ensure that those who do present at health facilities, particularly for antenatal services, TB, and STI services, get the HIV testing that they need. We should also be offering HIV self-testing, including within health facilities, both to decrease the time people spend at facilities and to support index partner testing. Concurrently, we need options for testing outside of health facilities, and these should be strengthened both with increasing the availability of HIV self-testing and accompanying follow-up and support, as well as through community testing with adequate infection control practices. We also need to acknowledge and adapt our services to reach people not engaged in care, and this is not a homogeneous group. As highlighted here, those not engaged in care include those who are ART naive, both those who know their status and don't know their status, as well as those who are currently in a treatment interruption. In the most recent Global AIDS report from UNAIDS released at the beginning of July, they highlighted a gap of 3.3 million people who do not know their status in order to reach the first 90. But there's even a larger gap, a gap of 5.4 million people between the first and second 90. And so clearly it's time that we acknowledge this huge group of people living with HIV who know their status but are not accessing treatment. And in the context of COVID-19, it's now more important than ever to inform people living with HIV about the importance of being on treatment and make sure we can support them in reinitiating or initiating getting the treatment they need, being adherent, and becoming virally suppressed. Now on to differentiated prevention and specifically PrEP. We must simplify, demedicalize, and differentiate PrEP. So for too long, PrEP access, uptake, and retention has been limited. And we can adapt the when by increasing the duration of PrEP refills, adapt the where and allow PrEP services to happen outside of clinics, adapt the when and increase task sharing, and adapt what to include a broader complement of services that promote self-care and self-management, including around family planning, HIV self-testing, and self-sampling for other STIs. Differentiated PrEP has really been catalyzed during COVID-19, and in data shared during an AIDS 2020 virtual satellite, I'll share some examples of this. So in Thailand, the Institute of Health Research and Innovation extended PrEP refills and prescriptions, increased telehealth, and is providing express services in addition to promoting self-sampling and testing. In Ethiopia, PSI is providing PrEP to female sex workers and has adapted the building blocks of when, where, and what. And continuing with this trend in South Africa, WITS RHI is strengthening PrEP delivery, particularly to adolescent girls and young women, through mobile clinics. COVID-19 has had silver linings for enabling service delivery adaptations to HIV, and we must take this opportunity to pause and think which adaptations these could and should be sustained and which should be supported going forward. As is stated in this slide here and is the third takeaway point, in the rush to return to normal, consider which parts of normal are worth rushing back to. Thank you. And please do share with us your innovations and DSD models that have responded to COVID-19. Please check out differentiatedservicedelivery.org to learn more, sign up for our quarterly newsletters, and make sure that we hear from you and share your experiences with others. Thanks very much.